bring up the issue of cultural competency, and that doesn't just go for Black and brown women. I mean, this goes for Asian women and American Indian women and areas where the predominantly white medical culture doesn't necessarily understand where people are coming from in other cultures, and very specifically why they wouldn't take their medications. Well, I told her, why wouldn't she take her medication? Well, because you needed to put it in a different context, and maybe people in that culture don't take this kind of medication for this kind of condition, and there's a workaround.
I think now is really the time to go beyond the macroaggressions and really look at, okay, I have to be part of this. If our system is suffering in such a big way, I have to be active and look for implicit biases. And these are things that, are part of maybe daily conversations and recommendations that obviously we're not as cognizant of. And this is a good gut check that it's time to do that. And it's a very hard conversation to have with each other as colleagues. And I think an even more difficult discussion to have to ourselves. But I have been seeing, thankfully, a lot more discussions, and even within hospital training programs. And I saw an article out of Harvard about training doctors with implicit bias and how to recognize that. And I think a big part of that came about. Sorry to again stall your discussion, Terry, but because a lot of the complaints, and you're definitely going to get to this in maternal mortality and even just treating women in general, is they're saying the right things. A lot of these women are telling you, hey, I'm heavily bleeding after my delivery, or I have this headache, my blood pressure is this. They're saying the right things, but how we're listening to it and receiving the news and processing and then formulating a treatment seems to be a major issue.
We all need to recognize and accept that we have bias and check yourself. And then you got to take it to the next level, and you have to check your partners. You have to check your residents. You have to check the staff. Like, we have to do a 360 check system within our medical system in order to ensure that we're providing the best care and realizing and recognizing that we have bias. I think racism and bias has just been like such a dirty term, and no one wants to accept that they may have benefited or behaved in a racist way or have been biased. I'm a woman of color, and I will explicitly state that I have biases. We all have them. And I think until we recognize that and then take the steps we need to take in order to combat those things, then we're just going to end up in the same place that we've been.
We started off the conversation talking about how healthcare, and so, I'm stealing from Dr. Dada, who kind of made this suggestion in the first place, but how healthcare probably kills far more people in an unjust, inequitable way than the justice system's built-in racial and ethnic inequalities will ever do. And that's because of data we have associated with morbidity, mortality across many different populations and many different disease conditions. But I'll use that as a segue to bring us back to Dr. Bennett and specifically to discuss maternal issues in either preconception issues or either peripartum issues or just gestational issues associated with inequalities and how those play out and how those hurt women specifically.
Sure. So we know for certain, and there's data to support this, that Black women are more likely to have a fetal demise, preterm birth as are Hispanic women, fetal growth restriction where the baby is very small for the age, mortality for certain, hypertensive diseases like having chronic hypertension, like high blood pressure or preeclampsia, as are our Hispanic women, obesity as are Hispanic women, late entry into prenatal care as are Hispanic women, and more likely to undergo a cesarean delivery. And those are just general obstetrical outcomes. There's also a huge list of looking at sort of severe maternal morbidity indicators. And we know for sure, I mean, I can go on with this list forever, that
Please do.
Black women are more likely to have a myocardial infarction, a heart attack, more likely to go into respiratory distress, more likely to need a blood transfusion, more likely to go into cardiac arrest, have a heart attack, more likely to bleed, more likely to need blood, more likely to need a hysterectomy where you lose your womb and are unable to have future children due to complications of pregnancy, pulmonary embolism, blood clots in the lungs, DVTs, deep vein thrombosis, which can also travel to your lungs your heart or your brain and kill you. So these are just really significant things that we know are plaguing Black and brown bodies more. And on a national level, the CDC recognizes that Black women are 3 to 4 times more likely to die than their white counterparts. And when we look at the New York City numbers, Black women are 12 times more likely to die than their white counterparts in data in the past. And though we think that number is improving and we're waiting for the most recent data to come out, we know that the gap is wide. And so we have to look at what are interventions, what are things that we can do to sort of, eliminate these health disparities is really our goal.
It's 12 times the rate.
It has been as high as 12 times. It's been improving most recently as New York State itself has improved some legislation. Cuomo has passed some legislation. De Blasio has passed some legislation, and they're putting money into the system. One really great program that I think will have a big impact is there's a doula program through Brooklyn where the government will pay for a doula for women of color who need that extra support.
Tell us what a doula does. Tell us what a doula does for someone in this regard, because it's important.
So a doula, in sort of layman terms, is a support system for a woman throughout her prenatal care, actually, and during the process of giving birth. And they can be someone to help to remind you what you wanted your birthing experience to be like, someone who can advocate for you, especially at times when probably you're in pain and unable to advocate for yourself. But they are really just like a friend, a support person who's going to have your back and help you to be okay and to have an uncomplicated pregnancy and delivery. And I'm a big advocate for a support person, whether that be a family member or a doula or both, because especially for Black and brown bodies, we need as much support as we can get, to be quite frank. And whatever is going to allow you to feel comfortable and supported, that's what needs to happen, because even perception of discrimination has been shown to lead to poor outcomes.